I was very generous to Dr. Ayman. It's actually 20 minutes, not 30 minutes.
Session 8. Try 8, try 8, try 8. Go back, 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 back. Thank you, Mr. Chairman. First of all, I would like to thank the organizing committee and in particular Dr. Faisal Shaheen and Dr. Abdullah Sayari for their kind invitation. It's a pleasure to be part of this well-prepared and organized meeting. So if you allow me to take you through my tasks today about the cardiovascular complications in transplanted patients. Let's see how this works. Yeah, okay, use that. So before starting, let me say that cardiovascular complications really, or cardiovascular disease can be improved, or the survival really is improved by organ transplantation. And if we take an example of the intima media thickness, which correlates with cardiovascular disease risks and events, if these patients go under transplantation, organ transplantation, there's a significant reduction of that thickness independent of other risk factors, and that's in particular in diabetic patients. And that has been shown to decrease the vascular events, and in particular myocardial infarction and stroke. And this is here you can see the pancreas transplantation and kidney transplantation show significant decrease in intima media thickness. And again here, if you compare, for example, with dialysis or with kidney transplantation alone, pancreas and kidney transplantation has significant improvement in cardiovascular disease. And if you look at those, all the incidents or events of ejection fraction, hypertension, myocardial infarction, and compare them with kidney transplant and with kidney and pancreas, definitely there is a much better improvement. So there is a beneficial effect of cardiovascular risk with organ transplantation. This is another good example. You can see on the left-hand side here the chest X-ray of a patient with valvular disease, and this is 1 month later after kidney transplant, and you can see the significant improvement in multivalvular heart failure. So let me take you back now. What are the organ transplantation, why it's associated with increased risk of cardiovascular complications? So cardiovascular disease is the first cause of death and graft loss actually in heart, lung and kidney recipients, but comes as second to malignancy in liver recipients. And comparing with liver transplant, heart recipients face the risk of aggressive coronary artery disease, whereas liver transplant patients come at a lower risk of cardiovascular disease. And if we look at different causes or different diseases or complications like obstructive coronary artery disease, arrhythmias, myocardial infarction, cardiac arrest, and so on, all these, we can see they are a major cause also of hospitalization. And if we take another example here of left anterior descending coronary artery, when there is a blockage somewhere there, ending up with acute anterior septal myocardial infarction. And these are some of what we can see sometimes in patients after organ transplantation from the blockage of the anterior descending artery or dilated left ventricle here, or dilated cardiomyopathy, and again you can see here the thickened left ventricle, definitely because of severe hypertension, which again you will see in a minute as a cause of or a problem, a risk factor for cardiovascular disease and post-transplant. I thought maybe I should briefly, these are unpublished data from our center really, but just give a flavor of what we are facing really. Like for example, we have something like 40% of left ventricular hypertrophy among post-kidney transplant patients, though it is mild in almost all of them. And diastolic dysfunction, and again about close to 50%, valvular calcification 14%, left ventricular enlargement 5%, and so on, less even incidence of other ischemic heart disease and mitral valve disease. But the good point I would like to mention here really is this: we've noticed that these events, what we see in post-kidney transplant of cardiovascular disease or complications, are very much related to other factors like, for example, age, obesity, duration on dialysis before transplantation, diabetes mellitus, hypertension, immunosuppression, and duration of post-transplantation. But I'll come in a minute to these risk factors. So what makes transplanted recipients at an increased risk of cardiovascular disease? This is either because there is a pre-existing cardiovascular disease before transplantation, or maybe exposure to general risk factor, or there is something more specific after organ transplantation, and in particular immunosuppressive medication. And if you allow me to take an example through, for example, kidney transplantation, there are so many factors contributing to the cardiovascular disease after kidney transplantation. But maybe one important thing really, which has been shown by KDOQI guidelines, that 90% of kidney transplant patients are, in fact, they are already in stage 3 to 5 of chronic kidney disease. So if that is the case of our patients, many of them already in chronic kidney disease from different stages 3 to 5, then we know from beforehand that patients starting, for example, here stage 1, stage 2 in red, green stage 3, and stage 4 and 5 here at the end in blue really, you can see the cardiovascular disease or complications becoming more and more progressive with the deterioration of renal function. And again, if you concentrate with me, focus on this graph here, you can see on the x-axis the glomerular filtration rate going down from 125 down to 0 here, and the mortality on the y-axis. And you can see here, the more deterioration of renal function, there is increase in the cardiovascular morbidity and mortality. And in particular, if you look at stage 3A here and 3B, when the deterioration of renal function, you can see there is an increased risk of cardiovascular really death by something like 46%. And if we compare really, that was on chronic kidney disease, but if we look at patients compared with the general population here, you can see dialysis patients at much higher risk really of developing cardiovascular disease. And if we add to that graph the transplanted patients, though they are much better than patients on dialysis, but they still much higher, something like 50-fold higher than general population at risk of developing chronic or cardiovascular complications after transplantation. I just would like here to show you, like if we have here a patient of 25 years old here, on this side here, who is transplanted, this patient carries a risk of cardiovascular complications or disease very much similar to somebody here from general population, or people 55 years old person from general population, or who doesn't have kidney disease. So transplant is definitely a risk. And if we look at different aspects of the complications, if we take, for example, the left ventricular hypertrophy or increase in the mass, there is definitely increase significantly in renal transplant patient compared with the normal. And if we look here at the risk factors for mortality in the first year, you can see left ventricular hypertrophy constitute a major risk factor. Again here for congestive heart failure, again left ventricular hypertrophy constitute a major risk factor. Even you look at 5 years mortality, again here you can look at the left ventricular hypertrophy, it's a major risk factor. And among different complications that might happen after organ transplantation, and in particular maybe kidney transplantation, among like infections, sepsis, malignancy, cardiovascular complications is the major complications. And if you look at different studies from the United States Renal Data System or the European EDTA or some other studies, and even in younger groups, less than 21 years olds from, again, the United States Renal Data System, you can see that cardiovascular complications is the major complication after that. So what are the risk factors? What makes these patients, transplanted patients, at risk? There are different ones. We can classify them either to low risk, if there is one risk factor, or no diseases beforehand, or high risk, especially patients with diabetes mellitus or metabolic syndrome, and those at very high risk if they have pre-existing cardiovascular disease or coronary artery disease beforehand, or a history of myocardial infarction. There is another way of classifying those risk factors. You can say that they are either traditional ones or transplant associated or the emerging risk factors. And for the traditional ones, either they are modifiable, like for example obesity, diabetes, hypertension, hyperlipidemia and smoking, or non-modifiable like age, gender and family history. And more specific, as I mentioned earlier, for transplant is immunosuppression, and there could be emerging like infection or inflammation. But what's really important among these risk factors is the coexistence of these factors. It's very unlikely to find a patient only with one risk factor or two. Usually there are more than one risk factors. But If I clarify that by a good example, they're like metabolic syndrome. Some patients before transplant, they might be obese or having hypertension or hyperglycemia or diabetes and or maybe dyslipidemia. But after transplantation, with the influence of immunosuppressive drugs, you can see there is more having metabolic syndrome. So the coexisting of these factors constitute a major risk really for having the post-transplant cardiovascular complications. And if you allow me just to quickly explain, the metabolic syndrome is basically defined as central obesity plus any of these two listed factors here according to the International Diabetes Federation. And when you have here abdominal obesity, anything of waist circumference more than 37 inch in men and more than 31.5 inch in women, blood pressure more than 135/80 or on antihypertensive medication, again diabetes, triglycerides or high density lipoprotein cholesterol. So any of these two plus central obesity constitute a metabolic syndrome in such patients. And the reason I'm mentioning this really because it is a major really risk factor in transplanted patients. And you can see a pre-existing cardiovascular disease make strength really, the strength of evidence is quite high really. We give here 4 pluses. Again, likewise, diabetes mellitus and metabolic syndrome, again 4 pluses, and immunosuppressive drugs. Then become, though they are important but less risky, is the cigarette smoking, proteinuria, and so on and so forth, you see, of other risk factors. And if you look at some risk factors like diabetes, dyslipidemia, and obesity, their influence on transplanted patients much more than dialysis patients. And if you look at post-transplant myocardial infarction, you can see the risks here of the age, the gender, female, the race as black, or ethnicity like Hispanic, who are predisposed to diabetes, and again diabetes and also organ failure or diabetes again beforehand. And if you allow me to take you through each specific risk factor, like for example the age here, and you can see on these 4 graphs demonstrating the myocardial infarction, for example here, and they are compared in fact with dialysis, chronic disease, and the bottom, the purple one, is the general population. So you can see the transplant, the dark purple one if you like, or blue one, this one, there is more risk here, for example, of myocardial infarction with advancing age, likewise with congestive heart failure, and again with peripheral vascular disease. With more age, the more susceptibility or risk of developing these diseases. And if you look at an example for ethnicity, and if you compare, for example, the South Asian and African Caribbeans with the European, and you can see, look at men and women here for the ischemic heart disease and stroke, definitely South Asian and African Caribbeans are at more risk of having ischemic heart disease and stroke than the European. If you look also at the fasting blood sugar and the dyslipidemia or high triglycerides, you can see the green one here represent the European at higher risk than the African Caribbeans, but this is reversed when there is systolic hypertension. Smoking, as you know, even in general population is of a risk for cardiovascular disease. But the good news really here is cessation of smoking before renal transplantation has been shown really to reduce the risk of cardiovascular disease. And this is one of the modifiable factors that we should insist on patients on quitting smoking. And if you smoke less, obviously you have better graft survival. If you smoke more, you have less patient survival. And again, here smoking, you can see more than 25 pack. Put it as a risk like some other risk factors like the advancing age, diabetes, and also pre-existing cardiovascular disease. Physical exercise fitness, not many patients after transplantation do exercise or become fit. And if you are less, or the patient is less doing physical exercise inactive, put at much higher risk really if you compare with patients doing moderate, and definitely much more than patients who are having active physical fitness or exercise. Proteinuria, up to 45% of transplanted patients, they have proteinuria. I'm coming to different causes of them, but it's also been known in many studies that it's really of a risk factor for cardiovascular disease. And this is, you've seen this probably the graph many times. When you have no albuminuria here, there is almost no risk really of having cardiovascular disease. And the more albumin excretion, the more cardiovascular disease, until you reach more than 300 where there is proteinuria, and definitely put patients at increased risk. And as you know, there are many causes after transplantation proteinuria, either glomerular disease, recurrent or de novo, chronic allograft nephropathy, acute rejection, calcineurin toxicity, mTOR inhibitors, and infection. The interesting thing that here with proteinuria, it doesn't go also with age, but also with body weight. And here you can see the black bars representing the body mass index above 30. It means that in obese patients, they are more susceptible again to proteinuria. So the things here accumulate together. You have advancing age, obesity, and proteinuria. So put these patients at even higher risk of cardiovascular complications at transplantation. And if we look at something like sort of dose response curve, if you look at the more proteinuria here, you can see the more loss of the graft, danger of losing the graft. And again, same thing at the patient survival. The less proteinuria, the better survival rate. The more proteinuria, the lower survival rate of patients. Hypertension is a major risk factor also, and there's so many contributing factors to development of hypertension. Either it's pre-existing before kidney transplantation or organ transplantation, or maybe comes from donor factors, transplant factors, but specifically immunosuppressive medications have a great influence on increasing the blood pressure. I'll come to that in a minute. And there are other reasons for transplant dysfunction like acute rejection, antibody-mediated rejection, or chronic allograft nephropathy, then the transplanted renal artery stenosis and transplant obstruction. This is a very nice graph to show you really the influence of increase in blood pressure. Here you can see the systolic blood pressure, and you can see the increment increased by 20 millimeter mercury. And here the diastolic blood pressure increased by 10 millimeter mercury. So if you have an increment or increase in systolic with 20 millimeter mercury and diastolic just 10 millimeter mercury, that will double the cardiovascular disease risk and mortality in these patients. Age, again, is very important. If you are having transplanted patients less than 50 years of age, by 1 to 3 years after transplantation, there is a significant drop of blood pressure and controllable. This is not the case if the patient is above 50 years of age, whereas you can see here up to 3 years after transplantation, still there is existent severe or elevated blood pressure. Steroids will come, this is known very much that steroids contribute definitely to hypertension, at least by increasing the sodium water retention and stimulate the appetite and increasing body weight. And other medications, the calcium urine inhibitors, they are known to cause a vasoconstriction, at least by upregulation of endothelin and inhibiting nitric oxide, causing vasoconstriction. Cyclosporine definitely causes hypertension much more than tacrolimus, and you can see 80 to 90% of transplanted patients who are treated with either cyclosporine or tacrolimus are in fact hypertensive. The interesting thing here, in patients who receive a bone marrow, before receiving cyclosporine, they used to have less than 10% hypertension, but after cyclosporine, the blood pressure increased 30 to 60%. It's even worse in heart transplant patients after cyclosporine because blood pressure increased from less than 10 to 70 to 90%. The good news again, in kidney transplant patients, if the dose of cyclosporine is reduced by something like 50%, then there is definitely a decrease in risk of hypertension in these patients. And again here to show you the comparison between different steroids known to cause hypertension contribute largely like cyclosporine more than tacrolimus. Sirolimus on its own or everolimus, the mTOR inhibitor, they don't cause much unless the tacrolimus is combined with sirolimus, then there is a contribution to hypertension. Dyslipidemia is a major risk factor, not only in general population, but again here in post-transplant patient, and you can see the major effect really comes from the mTOR inhibitors. Having said that, it's the frequency of cardiovascular events or disease in sirolimus-treated patients are not as high as one would expect. This is probably because of their anti-proliferative effect on endothelium. And we come here to diabetes mellitus, which is a major risk factor, as I told you, either on its own or it's part of the metabolic syndrome. And you can see up to 25% in the first 3 years after transplantation, patient can have or develop diabetes. And this development is really significant in increasing the mortality rate. And the first year, you can see up to 15% increase in the new onset diabetes after transplantation. But as you can see in this study, whether you have pre-existing diabetes or the patient start develop after transplantation, both constitute a similar cardiovascular events in post-transplant. And here document that the more you have a blood fasting, blood sugar increasing, the more risk of cardiovascular events. And this is a good one really slide or study showing the hemoglobin A1C on the x-axis and the risk of developing cardiovascular mortality or myocardial infarction in particular, especially in the red, as you can see side. The more of hemoglobin A1C, a positive correlation, the more you have cardiovascular events or myocardial infarction. Now the good news really, if These patients, if the hemoglobin A1C reduced just by 1%, you can see a reduction of myocardial infarction by 14% here. And if you reduce again hemoglobin A1C by just 1%, there is a reduction of something like 16% of heart failure. That's apart from other risk factors. So what really contribute to developing or having more diabetes in post-transplant patients? There are so many factors, but I would like maybe to concentrate on the age, on hepatitis C infection, obesity, and immunosuppressive drugs. Here you can see somebody who is more than 45 years old have increased risk threefold than patient less than 45 in developing diabetes. Likewise, infection with hepatitis C infection, patients with positive hepatitis C, they have more 64% of them having diabetes compared to the 28% in the negative patients. Likewise, again confirmed in another study here. And the other thing, if you add to the infection of hepatitis C, one of the calcineurin inhibitors like tacrolimus, there is a 50% increase in diabetes. So that has influence also by medication.
Dr. Ayman, you'll have 2 minutes.
Okay, thank you. So obesity again constitutes a major risk factor of steroids, again as I've shown you earlier, and here showing the body weight in general population from United States from 87 to 2001. In general population increase in body weight, likewise even in the transplanted patients. And weight again steroids have influence, great influence, and tacrolimus here. And here the metabolic syndrome, which I've shown is strong evidence really, or strength in causing increase the complication, cardiovascular complications. And here you can see again on the effect of metabolic syndrome, the effect of different medications, dyslipidemia with mTOR inhibitors, and the hypertension dyslipidemia with cyclosporine, and hypertension with the steroids more. So how do we manage these patients briefly? Careful selection, adequate preparation, prevention, and or control of the disease. There are things that we cannot change, like age, gender, ethnicity, but metabolic syndrome one should control very well, especially maybe before transplantation, and well control and management of immunosuppressive drugs afterward. So I'll go quickly through those ones, maybe obesity, dieting, physical fitness, maybe sometimes surgical options needed. If you reduce or withdraw cyclosporine, definitely there is much reduction, significant in weight loss, increased weight loss. Again, physical fitness, improve the cardiovascular events or reduce it, and left ventricular mass. Again, the hypertension, I showed you this before. And again, the choice of a blood antihypertensive medication is important, like for example, channel blockers for patients with calcineurin inhibitors to avoid the vasoconstriction, beta blockers in atherosclerotic cardiovascular disease, heart failure, and the other things like angiotensin receptor blocker or ACE inhibitors for proteinuria. Hyperlipidemia, the most important thing is maybe the statins effect have been shown very much reducing low density lipoprotein cholesterol, reducing fatal, non-fatal myocardial infarction. Different studies confirm that. And this is showing the common drugs used, like for example, the beta blockers and calcium channel blockers, again statins here in these patients. And the management of immunosuppression, very important. You can see the trend here, the tacrolimus is increasing, mycophenolate increasing, whereas azathioprine is down, cyclosporine down, steroid is also going down, trying to control that. Before sending patients, discharging patients, these you can see the trend of cyclosporine is going down, the blue one, and taking up later by tacrolimus. Likewise here, azathioprine is down in pink, and green taking up by mycophenolate. Again here at the time of discharge, you can see the combination of tacrolimus, mycophenolate more than those of cyclosporine and mycophenolate. Again here, maintenance treatment, likewise with this combination, showing more prevalence. Reduction or withdrawal of steroids, again in deceased or living donors, is increasing, and avoidance of steroids at all completely is again increasing in different protocols. And this is showing you when you modify the immunosuppressive medication from cyclosporine to tacrolimus, there is a reduction in blood pressure. Again here, if you avoid the steroids, you can increase the insulin sensitivity. Again, you can see increase here, there, after tacrolimus, a drop of hemoglobin A1C here, after dropping steroids and tacrolimus. Likewise, for new onset diabetes is less with avoiding steroids.
We're running out of time, Dr. Ayman.
Again, yeah, we'll finish that. But sometimes when you change, you may increase proteinuria, like here from cyclosporine to sirolimus. And in conclusion, Mr. Chairman, cardiovascular disease after organ transplantation is related to high prevalence and accumulation of risk factors before and after transplantation. Metabolic syndrome and diabetes mellitus are well-recognized risk factors and are linked to immunosuppressive therapy. Reducing cardiovascular disease complications after transplantation may be best achieved by reducing the impact of these defined risk factors. Thank you.
Thank you very much, Dr. Ayman, for a comprehensive